Hey everybody, welcome back. Another episode of Goodreads. So we're actually taking this episode. This is a snippet from our larger 12-lead class that will be coming to FOAMfrat Studio. This Atrial Flutter series actually comes from Series 1 in the rhythm section. So if you like the content in this video, you can look forward to a much larger 12-lead class being released in Studio here soon. So we're going to talk about atrial flutter, and we know that atrial flutter actually forms a re-entry loop kind of isolated in the right atrium. And the reason for this is that there's some conductive tissue issues in the right atrium. Different tissues tend to either conduct faster or slower. It tends to be actually slower in atrial flutter, but this re-entry circuit tends to follow a predictable pattern because of the anatomical differences in the right atrium. And that means that we tend to get an atrial rate around 300 beats per minute. Now, how this manifests on the 12 lead, we actually get these nice flutter waves, often referred to as F waves. And this whole rotation, starting from the SA node as the impulse comes down the right atrium and then back up, actually is referred to as an anticlockwise A flutter reentry. There are a number of different reentry mechanisms that go on with atrial flutter, but this anticlockwise tends to be the most common. This is about 90% of the atrial flutters that we see is this anticlockwise rotation. So what ends up happening in this situation is that anticlockwise rotation of that 300 beats per minute actually does get conducted down into the AV node. But the AV node, in order to protect the heart, to allow for ventricular filling, the AV node will actually terminate some of those impulses. So oftentimes the AV node will kind of form a little bit of a blockade. And it's a misnomer. It's not your traditional AV nodal blockade. I tend to call it more of a physiologic AV nodal blockade because the AV node knows that the ventricles cannot sustain 300 beats per minute. And more often than not, the most common form of atrial flutter is for every 2 impulses that the atria sends down to the AV node. The AV node actually blocks 1 and allows 1 to go through, which means that from the atrial rate, our ventricular rate is cut in half. And this is referred to as a 2-to-1 conduction, which means that our ventricular rate is often 150. And this is kind of the reason why atrial flutter is so often missed, because at that cutoff rate of 150, kind of depends, our P waves tend to begin to get obscured in the 12 lead. And so I want to show an example of this. We have in this 12 lead a very nice ventricular rate of 150. And what I want to draw your attention to is lead 2 at the bottom. I want to show how these T waves are lining up almost perfectly in the middle between QRS complexes. This is kind of your first clue that you may be dealing with an atrial flutter of 2-to-1 conduction. And I want to show by zooming into lead AVL a little bit more about what's going on. We have T waves that line up perfectly in the middle between QRS complexes. You also notice we have these small blips just behind the QRS complexes. Now, what I want to do is map out from blip to T wave and show that they map out perfectly in line with one another. And so what's actually happening in this situation is that you are getting buried P waves in the T waves. So the small blip behind the QRS complex is a P wave, and then you get a P wave buried in the T wave, a P wave buried in the T wave, and so on and so forth. And this lends itself to the atrial rate of 300 and then that ventricular rate of 150 that you commonly see. This phenomenon where the T waves are burying P waves actually has a name, and it's known as the Bix Rule, and it is exclusive to the 2-to-1 conduction in atrial flutter. And more often than not, it's your clue to tell you that the form of SVT that you're dealing with is actually atrial flutter with 2-to-1 conduction with the Bix rule observed. And so in this situation, you may also find yourself kind of pointing out, well, lead V1 has some nice P waves up there, and that is very true. And V1 actually, when in doubt, tends to be the lead that shows the best atrial activity, because lead 1 is almost physically placed directly over the SA node if correctly placed. And so, yes, you may have noticed V1 in this situation, but generally speaking, in lead 2, that T wave lining up just between the QRS complex is the Bix rule. That form of SVT that you're dealing with is atrial flutter with 2-to-1 conduction.